Welcome back, everyone. We are live back here at Eyes on Dry Eye. Super excited to bring on my next guest, Dr. Laura Periman. Let's bring her on. You are on all day
everybody.
Today. I couldn't want anyone more so than you to be on. Thank you for like the third round here
so
through
sweet.
the exhibit hall.
Yeah, all about the service, all about dry eye. I mean, I told you way back when I love dry eye. Anything but dry, come find out why. And this is the place to be, to come find out why.
You're like rapping right now. I love this. So here is something that's really interesting that I want to lead with. I've got all this stuff here going on. But in our survey, and this is a fascinating statistic, probably my number one most interesting one, I think. Which dry eye treatments would you consider utilizing in clinic if you knew more about them? 757 respondents. The number one answer was intense pulse light IPL. A year ago, we chatted. I barely knew about it, and it looks like you're standing next to one right there. Give us a little overview.
Right? And terrible timing. There's somebody at the door. I'm going to ignore that because we're live.
UPS delivering some more dry eye products.
My gosh. Yes, probably. It's probably study drug for one of our clinical trials. Oops.
That's
anyway,
okay.
So yes, IPL. This is the a very recent generation unit, and the short of it is, it's my dry workhorse. I can throw that football farther downfield with my IPL than anything else I got in my toolkit. It helps everything else that I use in dry, and I do all the prescriptions, all the in-office procedures. It all works together. It helps everything work better. It elevates everything else we do in dry eye.
Yeah.
So it's my go-to, my workhorse.
Very cool. Well, we're going to get into it more. Definitely have some specific questions, but you know, you're always working on something unique, and you've certainly kind of alluded to different things throughout the show here. But you know, I'm really curious. Anything revolutionary we should keep our eyes on? Anything you could tell us?
Well, I'm not quite ready to spill the tea, but very, very soon. But let's just say, when you look to who your companies are to bring you innovation, to bring you engineering, to bring you products that you can trust, look to companies like Lumenis. Their engineering team is brilliant. They do such an amazing job building these boxes. These are the gold standards, IPLs. And when you look at the peer-reviewed literature, the vast majority of those papers around dry, MGD, rosacea, et cetera, are using this unit. And so when you're looking at gold standards, performance, results, efficacy, all of these things, I think you should be looking at the Optima.
Yeah, 100%. And so now's that opportunity of 757 docs, their number one choice. If they knew more about IPL, they'd be doing it more. So what can we tell them? I mean, give us the overview. What is it about? How does it work? Anything that will help those docs out.
Awesome. So it's not a laser, and that's really important for medical, legal, scope of practice issues in various states. It's a broad beam light. It is not a laser. And so with this energy, I'm able to achieve many different things when it comes to dry eye disease, meibomian gland dysfunction, pathophysiology. That was a mouthful. But basically, there are 6 interrelated mechanisms of meibomian gland dysfunction. And this is described in the TFOS-2 report, Christophe Baudouin's 2016 BGO paper. Brilliant. There's a follow-up paper to that, Ocular Surface Journal, 2017, July issue, open access. Highly recommend you read it. But it explains the 6 interrelated mechanisms of meibomian gland dysfunction. And they are, I made a little acronym. I call it the BEASTO, RAR, right? The Beast of MGD, and he's laughing at your warm, wet washcloth. So when we're talking about meibomian gland dysfunction, we've got the bacterial compromise, the abnormal flora. We've got Demodex, those are the bugs. E is altered enzyme composition, and that's the gene expression that gets dampened by the I, which is inflammation. All those inflammatory cytokines of the T cells surrounding the meibomian glands, they're smoking and drinking and generally befouling the place. And those cytokines leach across the basement membrane and alter the biochemistry and the gene transcription inside the meibomian gland stem cells. Then we've got so that's the B, bacteria, bugs. E is enzyme. I is inflammation. S is stasis, or what I call constipation of the glands. T is altered melting temperature, and O is obstruction. And so it turns out there's peer-reviewed evidence demonstrating a benefit of IPL on 5 out of those 6 heads. The one thing it doesn't do as well is temperature, is to melt the meibum. That's where our in-office thermal pulsation modalities come in, thermal expression modalities. And we have 3 that are excellent, and I encourage you to use them. But when you take the time to address 5 out of the 6 heads, now everything else that you have in your toolkit works even better, because it's like, it's all hands on deck when we're talking about slaying the MGD beasto, right?
Sure.
So this is how I get there the fastest, is with that. And then I'll follow it up with in-office thermal MGD expression modalities. We have ILEX, we have great success with it, but I do it after I have control of the bacteria, the Demodex, we published on that last year. Inflammation, wonderful confocal evidence demonstrating improvement in the stasis, the thickening, the composition of the meibum, and the inflammatory cells that surround the meibomian glands. There's also awesome evidence showing how IPL drops the inflammatory cytokines with as little as 3 treatments. So it's a drug-free, procedural-based method for addressing meibomian gland dysfunction, ocular surface disease. Our own data shows even improvements in osmolarity, sometimes as little as 1 treatment.
Wow, that's pretty significant. So what drew you initially? And I think it's really important to understand, being a passionate person, like what is it about IPL that keeps you so, like, that enhances and maintains that passion for you and kind of gets you most excited?
Well, I think it's that broad mechanism of action. So you get thermal coagulation of the abnormal vessels, thermal immunoregulation, photobiomodulation wakes up the stem cells. We get photosanitization. There's actually IPL robots that go into operating rooms and flash sterilize the operating room. It reminds me of that scene from Men in Black.
Yeah.
Right. So there's a photosanitization aspect to it. Photocoagulation, photoimmunomodulation, photobiomodulation. All of these are, and then you get a photorejuvenation effect as well. I call that the share, if I could turn back time, aspect of the mechanism of action of IPL. So it's got all these really interesting mechanisms of action. We have published a video showing that you can kill Demodex epilated from the lash, put on a glass slide, boom, boom, boom.
I saw that.
Watch it just kind of go. Right? So I'll save a house spider all day long, but not these guys. So yeah, multiple mechanisms of action. I've got 6 years of clinical experience with it at this point, and I found myself frustrated. I've always treated dry. I've always loved dry. I'm a cornea specialist. I would send patients out to their dermatologist to receive IPL because I knew the correlation from reading Rolando Toyos's work that IPL helps rosacea-related MGD. So I would send them out for IPL, and they'd come back and say, "Oh, the doctor said I didn't have rosacea." I'm like, I'm looking at it under the slit lamp.
Wow.
So, and there's a disconnect between ocular rosacea and facial rosacea, but the two often go hand in hand. And so that's when I decided I need to get my own system. And since then, we use it every single day, and we haven't looked back.
Yeah, no, that's really cool to hear. So Dr. Robinson here has a question. If we assume 4 sessions of IPL, do you recommend heat/expression after each IPL or after the 3rd or 4th?
That's a great question. So I think that speaks to several things. One is the role of expression after IPL. Again, it's not a thermal modality. So if I'm going to express, like if it's that really thick toothpastey stuff, then I'll put the iEco hot packs on there for about 10 minutes first to get a nice melting after the IPL. But what's interesting about doing it after and not before is that you can observe, if you're a keen observer, you can see improvements in lid edema immediately after the procedure, including things like chalazia. We've pioneered that work using IPL for chalazia in a non-surgical, drug-free, drop-free way, which patients really appreciate. We have an IRB-approved study that's going on right now as well. So yeah, we've pioneered that work. As far as like the role of expression, it's a little unclear in the literature. Some papers do express afterwards, some don't. But here's the cool thing. It all seems to work, right? So it's a very forgiving platform. It's a forgiving modality. As far as the in-office thermal expression treatments, I plan hours after the 3rd or 4th because I want to correct that bacterial Demodex burden. I want to enhance that enzymatic activity. I want to control the inflammatory cells surrounding them. I want to improve the stasis, and we have confocal evidence of that. And then finally, I know I can improve instruction and then follow it with an expression modality.
Got it. Yeah. It sounds simple when you put it that way, actually. Now, for those...
Oh, good. I'm so glad.
Yeah, well, you make everything seem a lot more simple. So for those of you out there, by the way, do head to the Lumenis booth where you can learn more about the Optima IPL device, which Laura's got there behind her. So in your experience, how could using Optima IPL really help to enhance a practitioner's practice, grow their practice, help them out when it comes to treating more dry eye patients, and just overall, like you said, being a workhorse?
Right. So I think, at least for me, I started off with just a BioGlow strip and a prescription pad. That's all I had.
Right.
And this was way back in the day, and I'm just dating myself. So thanks for letting the seasoned clinician hang out with the cool young people. But and just since then, I've just layered on all these technologies and all these modalities, all these therapeutics, and they all have a role, right? It's just that I can achieve a rapid reduction in signs and symptoms of rosacea, meibomian gland dysfunction, dry eye disease. I can achieve those things clinically with this device. And what's so cool about this very modern platform is all of the safety features are built into it. It's a simple push a few buttons based off the patient's skin type. So it's taken a lot of the potential side effects out of the equation, or it just reduced the risks dramatically, significantly. So that enhances the safety and applicability for all of our colleagues. It used to be in the first generation IPLs, only dermatologists could operate it because you had to know wavelengths, light energy, but then there was no control over spikes in the light energy. And now we've got control with each pulse delivery. That's very important. This is the only platform where you don't get spikes on top. That's very important. And all of the pulse durations and the filters, all that stuff is baked into the software. So it's much easier for non-dermatologists to use.
That's fantastic.
And rosacea is such a comorbidity with dry eye disease, MGD.
Yeah. So, Lumenis is clearly committed to innovation. What do you see as next kind of upcoming in innovation for dry eye disease, dry eye management?
So their engineering team is amazing, and they're always coming up with some new things. We've got some work that we've done that's going to be announced soon. I can't quite spill the tea just yet, so be patient with me.
Will do.
There's some really cool innovations coming. Please watch for it. Please look for it. And I think that you will see that there's yet another elevation of the entire platform and clinical approach is what you're going to see. And I think that's what people really appreciate. Yeah, not only the doc, but the patients dig it too.
For those interested, head to the Lumenis booth and just check in. You'll be able to receive more information on that. Two great questions here. Dr. Ferrucci, can ODs perform this in every state? California?
So that's check with your state boards for sure. Check with your malpractice carrier for sure. And it's variable state to state. California changed their scope of practice laws about two or 3 years ago, and it went into effect January 2 or 3 years ago. So I think it's okay. Those languages are always written a little bit gray. So definitely consult your state board, your malpractice company, your attorneys. Just make sure that everything's on the up and up for your area. Yep,
got it. And if
stay on the safe side.
Yeah, for sure. And if anyone is in the chat from different states that actually have one of these, let us know. I'd be curious to see. Dr. Groves, Dr. Epstein had mentioned he thought IPL helps to change the saturation of meibomian lipids. Is there any clinical work looking at the biochemical changes that occur to meibomian lipids after IPL? Great question.
Oh, that's an awesome question. And thank you for that question, Dr. Epstein. I think he's referring to James Jester's work out of UC Irvine, where he's able to show that meibomian gland dysfunction is an alteration of protein to lipid ratio. And under desiccating stress, that ratio is altered and the meibum becomes even more abnormal. I'm not aware, and I'm hoping he'll share the link in the paper with me because I love reading the science, right? It's like the stuff gets my inner nerd a little Twitter-pated. But so as far as the expressibility of the glands and the meibomian glands yielding liquid secretions, there's the physicochemical evidence that you're improving the composition. But as far as like that HPLC, protein to lipid, SMS, radio signaling changes in the composition of the meibum, I haven't seen that yet, but I'm sure it's out there. We have focal evidence, we have physicochemical expressibility evidence, but as far as protein to lipid, I'm sure it's out there. I just haven't come across it yet. So, okay. Dr. Epstein, send me the link.
Yep. It was, so just so you know, it was Dr. Groves that asked it, quoting Dr. Epstein, who had talked about it.
Oh,
so, hey,
nice.
Dr. Groves, nice to meet you. Okay.
Hi.
Dr. Martin Robinson, I've had quite a few patients that refuse rosacea IPL, agreeing only to dry IPL. Is there good evidence to treat both? That would be more. Is there good evidence to treat both that would be more effective?
So did I hear that question right? Facial versus ocular rosacea?
Yeah, let me just repeat it just in case. I've had quite a few patients that refuse the rosacea IPL, agreeing only to dry IPL. Is there good evidence to treat both that would be more effective?
Great question. And so I think he's referring to the Periman protocol that we have YouTube videos on up that you can watch. But the Periman protocol is 4 steps. Step 1 is rosacea full face, except for the beard area in men, because you'll lose facial hair. Full face rosacea. Then the Toyo settings, the 590 photomodulatory settings. Then we switch to a small light guide with, you got to have corneal shields in place. You got to have them in place. In fact, let's color pair here. Nope, they're in the other sterilizer. You have to have corneal shields in place, switch to the small light guide, and then treat over the top of the lids. Not everybody does that. It's not clear if it's necessary. My attitude is you rob a bank because that's where the money is.
Yep.
And that's where the information is. And then step 4, the Periman protocol, is aesthetic cleanup. So the nasal angle telangiectasias, you can zap those with under the vascular lesion setting and facial telangiectasias. You can stack some extra 590 pulses on top of chalasia to help them resolve quickly. The acute ones resolve really quickly. The chronic ones take a little more time because their inflammatory cell profile is a little bit different. But those improve as well. And then in my mind, here's what made me treat the whole face first. I had this wonderful plastic surgeon come in with significant rosacea MGD. And I didn't have my IPL yet. And so he had his staff in his clinic do his IPL, and he only did here to here. And he came back in and follow up, and he looked like a candy cane. He was red, white, red. So that's what said to me, this is a local regional problem. And remember, ocular rosacea eventually can become facial, and facial rosacea is often associated with ocular rosacea. It's a 2-lane highway. It's a local regional problem.
Got it.
So I really push people that way. Plus, why would I deny you the aesthetic benefit? It takes me, 3 extra minutes, maybe 4. Why would I deny you the look better, feel better part?
Yeah, no, I appreciate that advice for sure. Now, last one here. So other than going to the Lumenis booth right now to get more information, what is the #1 piece of advice you'd give to practitioners looking to adopt this technology?
That's great. So ask questions, join Ocular Surface Docs on Facebook. It's closed to industry. It's just for clinicians to ask questions. Look at the videos that we've posted up. There's a learning curve to it. Utilize the trainers, but the learning curve isn't terribly steep. There's definitely some best practices as far as clean procedure room setup and some of the mechanics of how we do the treatments. I always like to do my treatments with the patient supine so that I can, with a 2-handed technique, I can visualize exactly where my light energy is going by working towards myself. I can see exactly where that light guide is at all times. So little things like that. But it's easy to learn. It's got a great safety profile. It's got a lot of utility and benefit.
Wonderful. Well, I appreciate all that advice. I know the folks in the chat, thank you for the questions, everyone. Appreciate those as well.
Yes, thank you so much.
Yeah, for sure. Dr. Periman, I'm sure you've got other sessions to attend. Either you're watching, learning, delivering, but thank you for all the contributions to this event. And for everyone out there, we've got a couple more sessions to go. Please enjoy. Oh, we got one more question here. Maybe we answer it really quick. Can you mention the study on confocal microscopy one more time?
Oh, you bet. First author is Yue Yin, Yue Yin, and it's AJO, September 2018, I believe.
Okay, got it. And if you remember, just
if you email me, I'll send you the link.
Okay, sounds good. Well, we appreciate it, everyone. Go to your conference bag, get the report, donate $1, or we'll donate $1 to Optometry Giving Site on your behalf. Have fun. See you later on. Thanks, Dr. Periman. Appreciate it.